Comprehensive molecular characterization of papillary renal cell carcinoma. Well, my name is Antonella Vitari, and this is my team. Definitions. Kidney cancer or renal cell carcinoma is not a single disease, but is made up of various types of cancer that are characterized by different genetic drivers. Each type has distinct histological features and a distinct clinical course and response to therapy. Papillary renal cell carcinoma, which accounts for 15 to 20% of kidney cancers, is an heterogeneous disease with histologic subtypes and variations in both disease progression and patient outcome.
These are kidneys. Each year, 65,000 people in the U.S. learn they have kidney cancer, also called renal cell carcinoma or RCC. And 33% of those people will already have advanced disease at the time of diagnosis, meaning the cancer has spread beyond the kidneys to the other parts of the body. Understanding this disease will enable patients to take an active role in determining the best management plan. So let's get started. There are different molecular pathways that allow advanced RCC tumors to grow. The two known main ones being the vascular endothelial growth factor, or VEGF pathway, and the mammalian target of rapamycin, or mTOR pathway. The VEGF and mTOR pathways are active in the majority of RCC tumors. The VEGF pathway is primarily responsible for the blood supply, which delivers nutrients to the tumor. The mTOR pathway is primarily involved in the tumor's ability of cells to grow and multiply, as well as the blood supply and metabolism. The goal of treatment is to block the growth of the tumor for as long as possible. There are different options available, and doctors will often use several therapies, one after another, to try to slow and temporarily stop the tumor. Healthcare teams may use different types of treatments, including surgery, radiation, chemotherapy, cytokine therapy, and targeted therapy, depending upon a patient's disease.
Continue pros and cons. Papillary renal cell carcinoma has two main subtypes. Type 1, which is often multifocal, is characterized by papillary and tubular structures covered with small cells containing basophilic cytoplasm and small uniform oval nuclei. 3. Various types 2, which is more heterogeneous, is characterized by a papillary covered with large cells containing eosinophilic cytoplasm and large spherical nuclei with prominent nucleoli. Another video.
For papillary cancer, for renal cell carcinoma, so there are two types. One is papillary type 1, the other one is called type 2. So type 1 actually has a higher frequency of a gene mutation. It's called MET mutation. So Dr. Shrari actually did a clinical trial with a MET inhibitor that showed some modest activity. But that c-MET inhibitor, according to his talk today, it's not a very pure inhibitor. So right now, I think they are planning to do another more pure MET inhibitor, and hopefully, this new MET inhibitor can have more clinical activity in this type of cancer. So right now, we are still relying on drugs that are for the common clear cell carcinoma to treat these rare types of tumor. But clearly, they have different drivers of gene mutation for this rare type of kidney cancer. So by using one class drug on another class or other classes of tumors, that may work well. So I think as long as we track the biology of this rare kidney cancer and design drugs to target these changes, the hope will be higher in the future. So I think for clear cell renal cell carcinoma, I think the future is bright. So we already have quite a few drugs available for this common type of cancer. For rare tumors, they are getting more and more attention from the oncology field. And once the drug companies figure out, these agents can be, especially these immunotherapy agents, can be used for the common kidney cancer, and once they are approved by the FDA, it's very possible that they can be used for this rare kidney cancer, because immunotherapy normally activates the immune system to attack cancer. So it doesn't care about which type of cancer it is. So I think from this standpoint, I think the future for this non-common kidney cancer is also brighter than before.
Application in medicine. We perform an integrative genomic analysis of 161 papillary renal cell carcinoma tumors to provide molecular insights into tumors classifications, inform clinical recommendations, and suggest paths to the development of mechanistically based therapies.
To better understand papillary RCC, what you have to understand is the big picture. And so overall, out of 100 renal cell carcinoma, 80 will be clear cell. We're not talking about this one, we're talking about the 20 left. And 15 of these 20 left will likely to be what we call papillary renal cell carcinoma. And it's based on the morphology, how it looks like when you look at the tumor with a microscope. And within this family of papillary renal cell carcinoma, there are usually two entities that are what we call the type 1, which tend to be rather smaller tumors, more localized to the kidney, or what we call the type 2, that can evolve more rapidly to metastatic disease. So these are a kind of renal carcinoma. There is no specific risk factor for this subtype, so we stay on the field of age 60 with known risk factors as hypertension or obesity, overweight. The thing is, we do also know that there are some inherited syndrome that does exist, and we can have that with papillary renal cell carcinoma. So there is some inherited syndrome with that kind of tumor. But what we do know is that for the first part of these papillary renal cell carcinoma, which are the type 1s, It's very likely that MET, it's a gene that codes for a protein that is on the membrane of tumor cells, is very important because we know that it can be mutated, and so it means activated. And MET appears as a relevant biological parameters in that kind of type 1 papillary renal cell carcinoma, and it may play a role as well in few type 2. PRCC, as all non-clear cell, has no specific therapy available. We use by analogy with what we do with clear cell renal cell carcinoma, and the guidelines always state that patients should be referred to clinical trial so that we could try to better investigate these disease and offer new therapy and all what the clinical trial brings to the patients in terms of accessing new compounds, because the results with the available agents that are approved are quite disappointing so far.
Issues applied in Ecuador. Pathological review of the 161 tumors identified 75 types 1 tumors, 60 types 2 tumors, and 26 tumors that could not be classified as a type 1 or type 2. The type 1 tumors were predominantly stage 1, whereas the type 2 tumors were frequently stage 3 or 4. These findings were consistent with those of previous studies.
So in this example, why don't we focus in on the left kidney? You can see that there are cysts in both kidneys, but there is a T2 hypointense mass arising from the left kidney. It's hypointense to the adjacent renal parenchyma. Now, if you look at the post-gadolinium images, the standard post-gadolinium images are a little bit hard to interpret. Is there really enhancement within this mass, or is this lesion just intrinsically a little bit T1 hyperintense? But I think when you're evaluating renal lesions, it's these post-gadolinium subtraction images that are absolutely vital for coming down on the right diagnosis. Notice that whereas it's somewhat difficult to identify the focus of abnormal enhancement within this lesion on the standard post-gadolinium images, it is clear on the subtraction images, particularly in the venous and delayed phases, that there is peripheral nodular enhancement along the posterior margin of the mass. Now, this is an example of a papillary renal cell carcinoma. Very faint, very subtle enhancement. The enhancement tends to be greater as you go along in the later phases, venous and delayed. And often the subtraction images are going to be vital in terms of identifying that rather subtle enhancement. Now, papillary RCCs tend to have low levels of enhancement. They're often going to be T2 hypointense, and I think that MR can be a great modality for identifying these lesions. I've seen several examples where it's hard to really appreciate definite enhancement on the CT scan, but the post-gadolinium subtraction images on MR really allow you to make the right diagnosis.
In conclusion, type 1 and type 2 papillary renal cell carcinomas were shown to be clinical and biological distinct. Alterations were associated with type 1 and activation of pathway was associated with type 2. Papillary renal cell carcinoma consists of at least 3 subtypes based on molecular. Thank you.